I'm Dr. Meena Chhabra and I'm a diabetes specialist at my own clinic called Dr. Meena Chhabra's Diabetes Clinic in New Delhi. Today I'll be talking about the immunogenetics of type 1 diabetes and how to differentiate between type 1 and type 2 in the young patient. Because of the rising incidence of obesity, we are now seeing younger patients with type 2. So, talking about the immunogenetics of type 1, there is a genetic predisposition because we've seen that siblings and or other first degree relatives of type 1 diabetics have a more than 15 times greater chance of developing type 1 diabetes. So, there is genetic predisposition, there are particular HLAs, the MHC or the major histocompatibility complex, which is important. Over and above, there is an environmental insult which then predisposes the patient to type 1 diabetes. So, do we go ahead and screen people who or siblings of type 1 diabetes? Should not be done in the general population, but yes, in the research setting it has to be done. So, what are the stages of type 1 diabetes? Stage 1 is when you identify an antibody. So, there are 4 types of antibodies that you could identify. These are anti-GAD antibodies, these could be insulinoma associated antibody 2, anti-insulin antibodies and the zinc transporter 8 antibodies. So, the stage 1 antibody is positive or maybe 2 also, but the patient is asymptomatic. In stage 2, multiple antibodies are positive, but the patient is now symptomatic but not yet diagnosed. And stage 3 is when there are a lot of symptoms of hyperglycemia, the patient develops polyphagia, polydipsia, polyuria, and he may present to the clinic with hyperglycemia. Stage 4 is when the patient has chronic type 1 diabetes. Now, can we do something about prevention of type 1 diabetes? Difficult. Yes, you can identify first degree relatives, you could do genetic testing, you can identify the HLA. You could also identify other genes other than HLA which can be positive. There are other 60 more such gene loci which could be positive. You could identify those. So, now you have a pool of patients who are genetically susceptible, but all of them will not go ahead and become type 1 diabetics. So, environmental insults are also important and they play an important role, so much so that after COVID we do see an upsurge of type 1, although data is not yet available. Now, what does the virus do? The virus can actually, cause certain changes in the beta cells, and therefore this environmental insult can ultimately lead to apoptosis of the beta cell and reduction in insulin production, and the patient becomes type 1 diabetic. So, we have to remember that it's not just genetic susceptibility but environmental insults, and this is clear because there is an increase in the number of type 1 diabetics disproportionate to the increase in the HLA which is important for genetics. So, that is why we now know that probably environment also plays an important role, diet plays an important role, the gut microbiota plays an important role, sometimes cow's milk, early weaning, all these factors, vitamin D deficiency have been implicated in the environment. Of course, epigenetics is also important, and in the epigenetics the gene is actually not changed, but then the methylation or the gene actually not changed, but there are certain changes in the gene that happen. This is epigenetics, even that could be responsible for the development of type 1 diabetes. Now, can we do something? So, if you have a patient of type 1 and the first degree relative, which is probably a sibling, happens to have antibody positivity, can we do something to delay the onset of type 1? There have been several trials, but most of them have not been successful. Of course, there have been some trials where oral insulin was given or subcutaneous insulin, and it was found that the period between antibody positivity and development of symptomatic type 1 diabetes could be delayed. That's all. The patient, if destined to become a type 1, did become type 1 if multiple antibodies were positive, but you could delay the progression by giving oral insulin or maybe subcutaneous insulin. But again, if the patient is already type 1 diabetes, we only have the option of treating the patients. So, most of the trials on prevention have not been successful, but more and more trials are happening. So, now how do you differentiate a young patient with type 1 from type 2? There are several pointers. Metabolic syndrome is present in type 2. may have stigma of metabolic syndrome like acanthosis, that young child may be obese. Usually it's an older child, not younger than 14, or then obesity is present. Some of our type 1s can also be obese because the population itself, childhood obesity has increased. But yes, other tests that can help us are antibody positivity. An antibody positivity usually points towards type 1. C-peptide we could measure. The C-peptide is very low or almost negligible in type 1. But again, type 1 is a spectrum. So initially they may have some C-peptide and later become, totally C-peptide negative, but there are also certain type 1s, certain endotypes like the endotype 1 and you have the endotype 2. Some of them who develop type 1 diabetes later in life, more than age 14, might have some residual insulin secretion for a longer time. So it all depends, but yes, it's important to differentiate other types of diabetes like MODY and type 2 in the young from type 1. So if the patient presents with ketosis or ketoacidosis, usually type 1, C-peptide is negligible or very low, it's usually type 1. If the child is thin, usually type 1, but a type 1 can also be obese. Stigma of metabolic syndrome present, it's usually type 2. So this is how you can differentiate between type 1 and type 2. Type 1 cannot survive without insulin, and you need to give them insulin for not just control but to prevent diabetic ketoacidosis. So this is the gist of my talk, that if a young patient comes to you, remember it's usually type 1, but it also can be type 2, and genetic susceptibility is important. Although almost 80% of our type 1 or 85% of our type 1s may not have a family history of type 1. Thank you.